Peter, for the introduction. Thank you for this opportunity to share our thoughts on the uptake and the general response we had to genomic sequencing for breast and ovarian cancer in the public sector. We have thus far pleasantly been surprised with the results obtained by the OncoMind multi-gene panel, and with some unexpected results along the way. And now that we have reached the 1,000 patient mark, we need to evaluate and decide on the way forward and determine whether we need to change anything. Just to recap, we all know that breast cancer is a common cancer affecting women worldwide and represents more than 25% of all the cancers globally. So of that 2 million new cases diagnosed per year, 25% will be breast cancer. And of that 25%, 15 to 20% will be due to an inherited predisposition. The incidence in South Africa is also increasing and is currently at an average rate of 1 in 32 women. And then in 2021, we published the most extensive BRCA1 and 2 series of the data we have at that stage. It was based on the NGS BRCA1 and 2 panel. So it was the results for the 2-gene assay. And in that, we had a positivity rate of 9.2%, with 137 patients testing positive for either a BRCA1 or 2 mutation. Many of these variants, however, represented founders, the founders that we've done the work on many years ago. And despite the increase in throughput that NGS gave us at that stage, less than 10% of the patients still got an answer regarding why did they get or were affected with breast cancer. So throughout the years, internationally, many predisposing genes have been identified, mainly, and one of the candidates was the DNA repair pathway. And we could not discard this assay based on the fact that we did not have any data. And that was the reason why we said, okay, let's tackle this pathway and see what's its applicability when we do a multi-gene assay, focusing on genes involved in this DNA pathway. And then at the same time, in order to validate this, the potential 15-gene panel, we decided to do exome sequencing on the side in parallel to aid with the validation and verification with the assistance of Professor Kotze from the University of Stellenbosch. So why did we pick this specific panel? Firstly, it was a curated panel of genes involved in homologous DNA repair pathway, of which BRCA1 and 2 are part of. But very importantly for us in the NHLS, you need to verify and show, and there's not always funds available to do that. So what was good about this was that the panel of the 15 genes used the identical primer sets that were used for BRCA1 and 2 in the 2-gene assay. And we had quite a lot of patient data that we could use and compare between the 2-gene and the 15-gene panel. The 15-gene expanded panel was designed for tumor blocks, and it provided an end-to-end workflow, which meant that we could continue using the Iron Reporter software that was freely available. Of the 8 genes included in the panel, only 8 is included in the NCCN guidelines for high-risk assessment for breast, ovarian, and pancreatic cancer. The other 15 is currently not included or covered, and that is what we need to determine is, should we continue with those that is currently not in the NCCN guidelines for testing and management, But now the latest guidelines also show that the genes included are well also associated with pancreatic and prostate cancer. As I mentioned, the NCCN guidelines, here you can see that even for BRCA1 and 2, there's a breast cancer risk and management, there's an ovarian cancer risk and management, and now it has even been carried over to pancreatic and prostate cancer for both of these genes. And that is why they are going to change the term hereditary breast and ovarian cancer, the term HBOC, or even the names BRCA1 and 2 is going to change in the future because it's no longer restricted to breast cancer only, because all these other cancer types are starting to show that it's valuable. As I mentioned before, all the other genes in the 15-gene panel, although they are not in the NCCN guidelines, they do, however, there's a lot of research being done on them, and they do seem to be critical for genomic instability, such as the MRN complex that involves NBN, the RAD50 gene, as well as MRE11. And in future, it seems like MRE11 will feature as an emerging marker for targeted radiosensitization strategies. And all these data were published in 2021, so it's relatively fresh results. And then one of the other genes, PPP2R2A, has again been associated with a poorer prognosis for prostate cancer patients. So these genes do have value. It's just currently they are more linked to target for therapy pathways and not necessarily for germline. Just to indicate where our samples are currently coming from, we have received up to now in 18 months' time more than 1,000 patients. They're requesting genetic testing using this expanded BRCA panel with an average of about 25 to 60 per month. Currently, we have 34 different referral laboratories nationally, with the main ones being Inkosi Albert Luthuli, Chris Hani Baragwanath, the Universitas Annex here in Bloemfontein, Groote Schuur and Tygerberg hospitals. Of the 900 patients analyzed thus far, the majority was diagnosed before the age of 50, so it's an early onset disease, and were of African descent. Mostly BRCA patients, breast cancer patients, were received with a mere 10 ovarian cancer patients. Even the prostate cancers were more than the ovarian cancer patients. And 19 of these patients had 2 or more cancer types. Just to quickly show you our workflow, so the patients are referred, whereafter DNA is extracted and quantified using purple EDTA tubes. And then for appropriate patients, we do population-directed founder testing. And that is mainly for the African BRCA2 founder mutation, 5999, DEL4, and the Afrikaner mutation or variant that is BRCA2 8162. Especially in the case of the Indian patients, they do not currently have any founders, so therefore we immediately proceed with them directly to the expanded research assay. And then afterwards once we get the data is done currently, the wet lab work is currently done in CAF, the CAF laboratory. The data is then analyzed, uploaded, once analyzed, and then we do our own variant interpretation. Currently, we do not make use of automated interpretation. We have a double system where Jaco and myself separately analyze and in the end make a decision, and then that result will result in the report. As I mentioned before, we did a small exome sequencing study for 18 patients, breast cancer patients with lobular carcinoma. And the reason for that is CDH1 is not included in this 15 gene panel. And we know that it is associated with lobular carcinoma and diffuse gastric carcinoma. So we wanted to see, we wanted to do two things. Firstly, we wanted exome data to confirm whatever it is that we are seeing using the 15 gene panel, as at that stage it was still unknown. And then the second one is we wanted to see what role does CDH play. Is it possible that the 18 patients might carry a CDH variant that we are missing? And then we had our final variant classification. So this is the result. Yes.
Was all of this on FFPE tissue or blood?
This is all germline testing using bloods.
Okay,
we have not ventured into the FFPE blocks as yet. We first wanted to see what does the panel look like, what is the quality parameters that we must be on the lookout for, and then once we are happy, we will start implementing it so that we can do both the blocks as well as the bloods.
Thank you.
So our positivity rate was 15.3%. It was up from only doing the BRCA1 and 2 a 2-gene assay. For we got 138 mutation positives out of the 900. The bulk of the patients was BRCA1 and 2. And then, as you can see on top of the list, 55 carried pathogenic variants in BRCA2, but of which 23 represented the founder variants. This is patients that did not have, that the genotyping was not requested for, and that immediately went through to NGS using the 15 gene panel. This was followed by BRCA1. So together, the founder variants, I must include CHEK2 here, the C1100del, was also observed in 4 CHEK2 patients. So that I counted together with the founder variants. So the BRCA1 and 2 founders, as well as the CHEK2 variants, represented 25% of all the positive results. And then BRCA1 and 2 together represented 66. But when we look at out of all the positive results, the total of 5 genes was responsible for 89% of all the causative variants. And that is quite significant. The rest of the genes, such as BART1, TP53, TP53 is there, BART1, and we had a BRIP variant and a FANG-D2 variants. They were all observed in a small number. We also had 3 double heterozygotes that was shared between BART1 and TP53 in one patient. We had a double heterozygote for BRCA1 and 2, and then also BRCA1 and NBN. Regarding the results that we got for the pilot study on using the exome, 18 patients was affected with lobular carcinoma, and as I mentioned before, CDH1 was not included in this panel. And we received results for 10 out of the 18 that had a personal and extensive family history of breast and other cancer types. I did say it was performed in parallel, so that helped with the validation process of the expanded panel. Although the positivity rate for the exomes looks quite high, 7 out of the 18, and we made use of a virtual in vitae 84 gene panel, the majority of that was, however, BRCA1, BRCA2, and CHEK2. The only unknown variants, truncating variants that we did pick up was in the gene KIT, which is a proto-oncogene involved in tumor development, and then PTCH1, which forms part of the hedgehog signaling pathway. And this variant or this gene has the potential to activate breast carcinogenesis when the expression of the PTCH1 protein is low. Okay, so what did we learn so far? We found that founder variants represented 25% of all the positive results. And that was mostly 2 of the 9 founder variants. So it was the Afrikaner and the African founder variant. This high number justifies performing this screen as a first-tier genotyping for all patients before proceeding with a more expensive NGS. But then we also suggest that the founder variant for CHEK2, the C1100G, should be included. If we do proceed with founders first, we propose that it should be done on a smaller scale and at the lowest cost possible, as we need to reduce the current first-tier screen from 9 variants to potentially maybe only 4. By utilizing the cheapest technology, such as the para-DNA system and point-of-care assays that Prof. Kotze and her team are working on, we might be able to incorporate positive controls and potentially recurrent variants also in non-BRCA genes as we go along. Regarding the multi-gene panel, as only 5 genes accounted for 89% of all the positive results, we should maybe consider constructing a smaller panel, going smaller instead of larger and bigger, in order to make it more cost-effective. If you have a smaller panel with less genes, you can do more patients on the same chip, which will make it definitely more cost-effective. If at a lower cost, the smaller panel could represent a second-tier screen, which could be followed then by exome or genome sequencing if it justifies the cost. Although the exome sequencing did deliver a high percentage of positives, the majority was observed for the known DNA repair genes. In the study, the depth, however, was too low, and some of the genes were not covered in their entirety. To correct for this, the depth and coverage needs to be increased, which is going to escalate the costs again on the other hand. Future studies using alternative sequencing options should be investigated, but in the meantime, performing exome sequencing on a research level could be of value. I recently had opportunity and the privilege to attend the 9th Symposium for Hereditary Breast and Ovarian Cancer in Canada in May this year. As the world's best researchers in the field was present and critical issues were discussed, I thought to share some of the interesting findings with you that eventually could influence the way we go forward. We all know this schematic presentation from Peter Deverley and Doug Easton very well. It was released in 2017, just when the first results of additional genes contributing to hereditary breast and ovarian cancer were published. The allele frequency is plotted on the x-axis with the relative risk on the y-axis. The various susceptibility genes were divided into 3 groups. We have the high penetrant genes, which is mostly BRCA1, BRCA2, and PALB2, and then the syndromic genes, such as Lee-Fraumni, Coden, and the Pearce-Jaggers, that is STK11, P10, and then TP53. And then we also have CDH1 at that stage that was indicated as a potential, at least a moderate impact gene. And then we have the moderate genes here at the bottom. They are a little bit more common in the population frequencies, but they are also at lower risk. Then 2 studies were released in 2021 that changed the way that we believe, that we thought or think of these genes at this stage. The Bridges study included 60,000 breast cancer mutation carriers and compared their data obtained for a 34 gene panel with that of 53,000 controls. Only mutation carriers with confirmed protein truncating variants clearly associated with disease were included in the Bridges study. The second study, called the Carrier study, compared data obtained running a 28 gene custom panel, and that was done for 38,000 cases and 35,000 controls. All predicted truncating variants were included, but they excluded the final exon and the last 55 base pairs. So when we look at the results, the Bridges study, there was differences between the Bridges study and the mutation carrier study. As you can see, for BRCA1 and the Bridges study, the odds ratio is 10.57, which differed between in the carrier study and with an odds ratio of 7.62. So the authors and the investigators thought, let's pool all these data together. And they even added some of ClinVar's missense variants that had a 3-star rating in ClinVar. And eventually they had a total of 81,000 unselected breast cancer cases versus 83,000 controls. And then that is currently the odds ratios that they have decided is acceptable and that it's common for between the three studies. So now we have an odds ratio for BRCA1 of 8, BRCA2 is at 5, and PALB2 is above 4. All three of these genes, because they have an odds ratio above 4, is now confirmed to be highly penetrant genes. When we look at the intermediate penetrance genes, we see that regarding the Bridges study, they struggle to get some of them statistically significant with only ATM and check and possibly BART1 in the top. Only ATM and check again in the second study, the carrier study was statistically significant. And then when they combined everything, we have only 2 genes remaining with an odds ratio above 2 that confirming to be in the moderate risk breast cancer class. Regarding the syndromic genes, the only one when the data was combined that actually proved to be clinically significant and statistically significant was TP53 with an odds ratio above 4, nearly 5. So that means that the graph that we know from 2017 has changed dramatically when we incorporate the data from these extremely large studies. So now they have, on this BRCA conference, they have claimed that what's in and what's out. Definitely the high impact of BRCA1 and 2 and PALB2, the odds ratio have dipped a bit. It's now below 10, but still confirmed highly penetrant. And then when we look at TP53, that has remained as one of the syndromic genes with an odds ratio between 4 and then 10. But then if we look at some of the other genes that had the potential or was previously classified as potentially being at least moderate risk to high, that's the RAD51D, RAD51C, ALBART, NF1, they are all now below an odds ratio of 2. And that will have to, that's going to impact how we think about what should be in extended panel and what genes we should be on the lookout for. What stood out at the meeting is that the landscape of genetic testing is changing with the approval of PARP inhibitors. Now patients are tested to assist with the selection of appropriate therapy and no longer only for germline testing to determine hereditability. This has resulted in amendment of the selection criteria, so much so that metastatic breast cancer patients are included. This is the list of patients that now should undergo germline testing. So they are propagating metastatic breast cancer patients should all be tested together or with those with triple negative disease. I think that corresponds with our current guidelines, and then hormone responsive and HER2 negative patients. Interestingly, they indicated that all ovarian cancer patients should be genetically tested because they are currently, the survival rate for ovarian cancer patients are extremely low. So when the trends of germline testing in patients with breast and ovarian cancer are evaluated, we see an upgoing trend in the prevalence of testing, although that of ovarian cancer is still below the breast cancer patients. Various meta-analysis studies indicated that although testing should be done, only 30% of high-grade squamous ovarian cancer patients get tested. This indicated that for ovarian cancer patients, we are not doing what we're supposed to do. If one considers that this is, in our current study of nearly 1,000 patients, we had 10 patients affected with ovarian cancer that were sent for genetic testing in our laboratory. Internationally, there's additionally a huge push for tumor first for all ovarian cancer patients. This has been successfully implemented in the Netherlands with success, and the world is watching to see the results, as the 5-year survival rate of ovarian cancer patients is low, as I mentioned before. The benefit is while information is gained for therapy, only 15 to 18% will need to be confirmed afterwards via germline testing. And just to indicate whether anything changed regarding genotypic, phenotypic correlations based on pathology, BRCA1 still explains the majority of triple negative disease. It is very aggressive. Normally, the tumors are very aggressive, grade 3. It has pushing borders and then also brisk tumor-infiltrating leukocytes. When we compare that to BRCA2 mostly have hormone positive, ER positive and HER2 negative tumors. That is normally subtype luminal B. Also grade 3 with pushing borders. And then here is where it overlaps with a possible image for CDH1. It also has lobular features, and that makes it a little bit confusing between a BRCA2. Is it potentially a BRCA2 variant, or could it be CDH1? Regarding the results for BRCA1 and 2 and triple negative disease, this is the results of the SIMBA study. Here we can see as the age of onset increases for BRCA1 mutation carriers, you will see a drop in the triple negative tumors, whereas for BRCA2, it's the opposite picture that we see. There's an increase as the age increases. Even PALB2, now they have determined there is distinct pathology for PALB2 ATM and a gene such as CHEK2. For PALB2, it's also ER positive in the majority of cases. It varies between grades 2 and 3 and also varying histology. It has a lower level of the tumor infiltrating leukocytes than BRCA1. And then ATM and CHEK2 to some extent corresponds. It is mostly ER positive, HER2 negative. And then for ATM, the majority is low grade, but there's an enrichment for a grade 3 tumors. And then whereas with CHEK, it can be either ER positive or HER2 negative. But then there's also this enrichment. And very interesting theme that surfaced during the conference is that the tumors that falls within the first part of the DNA repair pathway behave and is characteristically different compared to the rest. Here we have BRCA1 and 2 ovarian tumors. Most common histological type were high-grade serous carcinomas, and the frequency of finding a BRCA1 and 2 germline variant in these tumors were 25%. With such a high percentage or chance of getting a BRCA1 and 2 germline variant, why are we not currently receiving these patients and testing them? So this is a big gap that we should address in the near future. There seems to be a correlation between the phenotypes of closely associated mutated genes involved with breast cancer. We all know that BART and BRCA1 is very closely associated, the same with the triple negative disease. Although BRCA1, the odds ratio for triple negative disease is extremely higher, the two correspond. The same can be said for BRCA2 and PALB2. PALB2 is the localizer of BRCA2, and then and RAD51C and D. Importantly, here again, the sensors upstream in the DNA repair pathway tend to be different. Here we have the majority of the breast cancers in this category, in these two genes, are hormone responsive, HER2 negative, and is of a low grade. There's not a lot of triple negatives that you will find in ATM and CHEK2. How do these genes differ then regarding their sensitivity to PARP inhibitors such as olaparib? This tends to vary between the different genes and the specific gene, the type of alteration, and the therapeutic response. Here at the bottom graph, you can see in the red line is the BRCA1 response, ATM is the blue line, and then the black is the wild type. When we compare that with the figure on the other side, we see that the red line represents BRCA2, a very good effect but when you compare it to ATM, there's not such a good effect of using olaparib for ATM. And when illustrated in the clinical trial, the blue indicates that there's a minimal signal of association. The graph on the right-hand side indicates the best germline overall response to olaparib based on the variance in the various non-BRCA genes. Patients with pathogenic variants in CHEK and ATM, that's the blue lines or turquoise lines at the bottom, benefit a lot less from olaparib than patients with PALB2, BRCA1, and BRCA2 variants. So where to next? The participants and the leaders in the field says, we are not going to find anything else similar to a BRCA3, a high-impact BRCA3. This study was done using 2,135 BRCA-negative cases, and they used exome sequencing to screen them and compare them to 51,000 controls. They did it in a stepwise fashion. The first was where they used 86 breast cancer susceptibility genes. They screened for them using a virtual panel. And then just to clarify the different colors, the dark green is that of protein truncating variants. The light green symbolizes missense variants. And then here at the bottom, if you look at the odds ratios, symbols indicated in yellow that was significant after correcting for multiple testing. And that was only present in the figure A for PALB2, ATM, and CHEK2. For TP53, NF1, and BART, that's the pointer. Let me just use the pointer here. For these three genes, although they initially were significant, they were not withstanding correction for multiple testing. So regarding all these, regarding the virtual panel for cancer susceptibility genes, there was absolutely none of the genes that was not the known breast cancer susceptibility genes that tested significant. If we look at the second graph, the DNA repair genes, they looked at a total of 276 using virtual panels. Again, only the top three, PALB2, CHEK2, and ATM, proved statistically significant, with the rest falling out. So, and then the final step was where they looked actually at everything there is, and then still there was limited or different genes currently unknown that came up, but none proved to be statistically significant. So there was minimal signal association in the known non-breast cancer susceptibility genes. So we do not expect to find a third high-impact breast cancer gene. The genes that might come to the forefront will be similar to a moderate gene impacts such as ATM and CHEK2. So, and even if there should be a high penetrance gene discovered, it will be at an it will have an extremely low minor allele frequency. So everybody is asking, where is the missing heritability? So that could be in the non-coding variants that we are seeing. Nobody is actually looking at them. The moment it is beyond 25 base pairs, even us within our pipeline, when it's beyond 25 base pair of our splicing junction, we do not investigate it any further. And then another possible cause could be inherited promoter hypermethylation. If you look at this table here on the right-hand side, here you can see the frequency in population of pathogenic variants. Our genes with an Arch ratio above 4, our highly penetrant genes, it's about varying from BRCA2 is the more common one, with PALB2 is 1 in 895. And then we get to the syndromic genes that's even more rare, but then our moderate impact genes, CHEK2 and ATM, again, is a lot more common. So just to say, I've mentioned before that now the NCCN guidelines have included prostate cancer within the guidelines for when we screen for using this multi-gene panel. So regarding prostate cancer, we see that it's actually a highly hereditary type of cancer, even higher than what we see for breast cancer or for ovarian cancer. And what was discussed is that they do not, although lots of men do not pass away or die due to their prostate cancer, especially BRCA2 mutation carriers have a very poor survival. And that is important why we should screen actually these patients. It is considered, that the prostate cancers, we should see them a lot more because there is actually something that we can do for them. If we look at metastatic, this article on metastatic prostate cancer, here we can see that BRCA2 is playing a major role. 44% of patients had a BRCA2 mutations. That was followed by ATM, CHEK2, and BRCA1. And if we continue with the circle, we have PALB2 in the panel, we've got NBN in the panel, and then we have up here our MRE11 and BRIP1. So if we look at selection criteria for BRCA2 carriers, who should be tested? Men with metastatic disease, high-risk patients that has maybe a T3 staging, at least Gleason score between 8 and 10, and possible lymph node involvement. And then men with a family history of 1 or more relatives with prostate cancer, or then 2 or more close relatives with prostate, pancreatic, ovarian, or breast cancer. Typical BRCA2 mutation carriers in prostate cancer carriers is the average survival currently is 5 years. So it's a bad prognosis when you carry a BRCA2 mutation. The tumors is normally of a higher grade, and then they are diagnosed a little bit younger. So the recommendation was among the oncologists attending the BRCA2 2023 symposium was that if a biopsy, the PSA level is higher than 3, these men and patients should be referred for a biopsy. Other genes involved in prostate cancer, the main one is HOXB13, which is currently not part of our extended panel, but the main genes are in this panel that we are currently screening. Men with metastatic prostate cancer tend to do better using olaparib. It's the blue line compared to the placebos. And then also they have a better quality of life as there is no progression of pain. There seems to be no progression of pain. Regarding pancreatic cancer, that's our fourth main cancer type that can be identified using this expanded panel. Here we see whether it's metastatic or not. It's indicated for any pancreatic patient. And then again, they do seem to do a little bit better on olaparib compared to the placebos. And then here we see for pancreatic cancer, there's a 12% of survival above 5 years. And currently the data suggests every patient should be tested because 17% of all patients carry a pathogenic variant in one of these three genes. So we do have something to offer for even pancreatic cancer patients. But there was a stern warning. Again, these two genes that function in the upper part of the DNA repair pathway, they made it very clear that these two tumors representing patients carrying ATM and CHEK2 carriers, there's no signs of homologous recombination deficiency, and they should not be treated the same way as the above patients with BRCA1, BRCA2, and PALB2 carriers. And I'm not an expert on the biomarkers, but it seems to that the pancreatic cancers can be also classified in a similar way than the breast cancer tumors, like basal. So it seems like there is currently biomarkers emerging that could assist with identification of samples that should be patients that should be referred for genetic testing. The more DNA instability, but the message is the worse the outcome. So how do we improve our service? I always felt, and I still feel that way, that we are missing the family members. We do screen the affected, and we do that in the hundreds, but we are barely seeing unaffected individuals in these families. And this is very important because the affected or genotyped or mutation carrier is the key to the entire family of individuals. And if we can perform a pre-symptomatic test or a predictive test that can assist with the treatment of these unaffected family members, we have the tools to identify whether you are at risk or not. But these patients are not, the individuals are not coming back because we are missing some way the message of what it means to be a mutation carrier is missing. So internationally, they have the same problem that we are struggling with. So they recommended that selecting or choosing a champion, a family champion, somebody in the family that can act as a champion to spread the word, to explain in a understandable language to family members what is the risks, what are the benefits of being tested, so that this is one of the big areas where we can actually make screening for the state patients more available, cheaper, because now you don't have to wait. The patients will be aware of their risk, or the individuals will be aware of their risk, and then we can put them in screening and surveillance programs to prevent cancer occurring, because the treatment of a cancer is way more expensive than getting by this time, if you have a family member, a known mutation carrier within a family, the cost is so small when compared to treating a patient affected with cancer. And then the other deficit that we have to look at is when we compare the number of men that gets tested compared to the number of women, because out there, the majority sees breast cancer as a female disease. That's why all the females are referred for testing, but we do not see the men. But now with the guidelines expanding or extending towards prostate cancer as well as pancreatic cancer, I think we might see a change in this ratio between male and female. So what does it mean for us? We wanted to see what is the success of the expanded panel with the 15 genes. So it seems like for a lot of our patients, they get referred basically to determine their treatment. But if we do the hereditary path and we do the germline in the blood, our big focus must be on this latter part. It's where the champions of the families are involved. We need to get the word out. We need to counsel on a patient level, using layman's terms. The patient and the extended family members must be able to grasp the benefit of the ski that you have to the family. And then if we go the treatment route, I think it's time that we maybe open up tumor testing for the ovarian cancer patients, as the recommendations are that each patient affected with ovarian cancer should be tested. And if we can do it by means of using the PPE blocks, then we can at least start to see what is the quality, how does it impact on our panel, is there something that we should be aware of? And once we have that done and sorted out for the ovarian cancer, we can maybe open it up for the breast cancer patients as well. So the moment you find then a likely pathogenic or a pathogenic variant, you have to confirm it then the hereditary part of the tumor by doing a germline testing on the blood. So we definitely believe there is room for a first-tier genotyping assay, a first-tier test that get rid of the most common founder variants that we are currently seeing. If you can pay less than 1,000 Rand for a cheap first-tier genotyping assay, compared to an 8,000 Rand NGS-based assay, that is the way to go for the public patients. And then we might get criticized by going backwards to smaller panels instead of moving forwards to bigger. But bigger is not always better. In this case, we got positive results. 89% was explained by only 5 genes. So should we not consider doing the smaller panels, get those 90% positives identified, and then if they still test negative and there is justification for it, continue then to genomic sequencing. I think that for the public patients might be the best route to go forward. Thank you very much.
Okay, thank you very much for this excellent talk. I'm sure there will be very many questions. So anybody with a pressing question, please unmute yourself so that we can then take the questions. I'm sure that the genetic counselors, that is quite a lot of them, if they could contribute to this, maybe have some ideas to share with us, we much appreciate it.
Prof. Marita, can I go first?
Yes, please, Rispa.
Yeah, thanks a lot, Nerina, for that excellent talk. I really appreciate the work that you do. It's a lot of work, but it's really informative. We have a question here from Kenya. People would like to know the cost of the panels that you do. Like, for example, we have a patient, a breast cancer patient that needs to be done genetic testing. I really don't know how you will group that patient. Will we go for panels? And if yes, which panels, and how much is it likely to be?
Currently, we are, for the 15 gene panel, we are charging approximately 8,500 Rand. I'm not sure what's the exchange rate between us and Kenya, but that is in South African rands. That's our price for the 15 gene. So we are expecting maybe some changes here in our workflow in Bloemfontein, because there are a possibility of getting our own sequencer. And the moment we get that on site, we are going to look again at the construction of the panels, where we should go. But for now, it's 8,500 Rand for the 15 gene.
Okay, thank you.
Waiting from Claire. I see there's a question from Claire.
Can you see it?
Yes, currently in the NHS, we only offer testing for BRCA1 and 2, PALB2, ATM check, RAD51C and RAD51D. So a small panel which has only recently expanded. There's a pilot study in Manchester doing whole genomic sequencing on all ovarian tumors with germline testing, if indicated, based on, what's the way? Then she used an abbreviation I don't understand, of detected variants. So yes, it seems like I agree. I think in our scenario, in our third world country, there's always a shortage of funds. I do not, that's my personal opinion, I do not think bigger is better. So my colleagues and I still have to decide which way we are going to go. And I think if there are stakeholders, doctors, oncologists that are willing to share their preference or the insights into what they think would be best, we would appreciate some feedback based on the talk. My email address, I can provide it, and Prof. Kotze also has it, so that we can determine the way forward. But I, in my mind, think we should go back, a step back, and do as a second tier. First tier is the genotyping of maybe at the most 4 specific founder variants that we are seeing commonly in our patients. And then the smaller panel as a second tier, and then we can think about the exomes and the genomes. I don't know.
I agree that if we can then also link it to a research project, we can try and find funding for the extended WES analysis and so on. But I think there's a question from Dr. Frank Onayambu, if he would maybe just unmute himself and ask his question.
Okay, thank you for a great talk and very informative. And thanks, Dr. Tororei, for inviting me to join today. So I actually have a question regarding cost as well, but I'm curious, will it make it cheaper or more accessible if the panels were done on a different platform that is not, where you're not using proprietary bioinformatics? For example, if people generated amplicons and sequenced these on Illumina or MGI, I'm wondering what your thoughts are on that, because we have access to those platforms here in Kenya, but we don't have access to Ion Torrent, at least in my institution. Thank you.
I'm going to hand this one over to my colleague, Jaco Oosthuizen, as he is up to date with the technologies and the different pricing.
Hi. Yes, there's definitely a difference in the scalability, low, medium, high throughput. So the different chemistries do allow different scalable platforms. And always the larger you go, the cheaper it gets. But the core rule of thumb that one always has to remember, in panel sequencing, it's the cost for the amount of primers. So a smaller panel will be cheaper because you have to synthesize less primers. Bigger platform, you're going to have to sequence a couple of 100 patients in a single run if you use a very small panel. So that's where exome sequencing becomes then more cost effective. So it's always difficult to explain to a clinician from a technical point of view where the Goldilocks region in costing analysis comes in. Golden rule, primers is more expensive.
So in my case, we have a MySeq in my facility. Like, will it be comparable, you think? Maybe it's an unfair question.
No, the MySeq is your medium throughput at this point, but you have to take in consideration that the MySeq uses a 4-dye color system, almost like the old Sanger sequencing. So Illumina does have cheaper options. That is a 2-dye chemistry that cuts down on the fluorophore cost. But even on the MySeq, it does have different flow cell capacities, but it still depends at the end of the day, what is your panel size. Sequencing on a MySeq, anything from 600 to 800 Rand for the chemistry, for the sequencing chemistry, but you're going to pay still a couple of thousand for the primers.
Thank you.
Okay, then I see that there was 2 people with a question. There was someone just before Chantel Scott. I can't see the name now. Can you just maybe unmute yourself and then ask the question before?
Yeah, it was me.
Okay.
Nerina, I had a question and a comment. I just wanted to ask, I saw a lot of the patients that had been referred for testing were coming from Albert Lutuli. And then a lot of them obviously come from departments where the like genetic counseling services are actually in, you know, in the system. And I wanted to ask, the ones from Albert Lutuli, are those coming from the breast clinics, or are they coming from the genetic service there?
Currently, I have a collaborator, Dr. Ines Bakamaza. She is the oncology surgeon working at Inkosi Albert Lutuli, and she has 2 genetic nurses that have been there for years. And Nomita Chabila was a genetic nurse that started referring many years ago. So I think they, although they are not official counselors, they do perform, they do sit with their patients and refer appropriate samples. We had quite a lot of positives for Inkosi Albert Lutuli. But when you compare the positive results that we see for the different centers, it is very true that when they come through the genetic counseling services, your chances of having a positive is a lot higher than just at random samples getting to our lab, barely with any clinical information. I told Yaku the other day, I think we should start refusing or rejecting some of these requests, because there's absolutely nothing on it. Sometimes you can't even see if the patient is affected or not. So I think if our request form is not completed, or there's at least some description at the back of the request form, I think we should start rejecting patients, because there's definitely value, and we can see that in the results when they come through a genetic counselor.
Yeah, I was asking just because there was a large amount, and you were talking about this lack of family uptake, which we know is not unique to South Africa, but
Yes.
I wondered if them being seen through non-genetic services was perhaps contributing towards that, in that they're not really getting the prompt from whoever's requesting the testing to actually then communicate that result with the family and, you know, go from there.
No, I think the genetic nurses at Inkosi Albert Lutuli were doing an excellent job.
Yes, I know, we know them. They're wonderful. Yeah.
Yes, yes.
Yeah. And then I was just going to say, the one other comment was just this idea of pulling back. It was a bit tricky when you are in a setting like ours, where you've got a completely different demographic of population. The studies that you were talking about are presumably European-based studies, and you then run the risk of kind of excluding genes that might be more appropriate for our population. So I guess it's always a bit of a tricky situation, but it was a lovely talk. Thank you so much.
Okay, no, they did. It is true. Even when we look at our variants, we do see differences, but in those massive studies, they do have African data included. I know it will be at a small scale and not be completely representative. But even for BRCA1 and 2, we are currently in every run, we are still seeing new variants that we have never seen before. So we thought after more than 2,500 patients screened using NGS that by now we should have seen all the BRCA variants, but it's not true. They're still there and they still require investigation. So I think regarding the various genes, currently the bulk of the patients that we have now in our database, or in our variant list at least, is the majority is African. So we do see unique things, but we also see stuff that corresponds with literature out there. So somehow in the near future, not today or tomorrow, but we will keep an eye out on, is this really something that totally differs? And the more we get African patients from outside of South Africa, that can also contribute to expanding our variant list and the value. That's why Prof. Kotze and I and Jaco talked about starting a African consortium. Everybody has a consortium except the continent of Africa. So if we can start an African breast cancer consortium and get to share data. So if we pick up variants and they pick up variants, because sometimes you would see when you compile a report that this variant is extremely rare. And then when you look at the demographics, those patients represent possibly an African SNP, and it's also describing ClinVar as such. So if we can start by combining different African countries' data, that would be so powerful in variant classification, you know, going forward. I think, I don't know about leaving some of the genes out. For now, we will continue. But I think when our situation change and we really want to evaluate what it is that we want to do effectively and at the lowest cost, then I think we might cut down and not expand.
But Nerina, that would also form part of the PhD of Jaco, to look at those frequencies and so on. Is that right?
Yes, no, he will look at that. That's true.
Okay, and also just want to, for myself to clear, I think the comment was that it's mostly European ancestry people that you test, but for this around 1,000 cases, I think it was majority Black Africans. Is that right?
Yes.
Yeah,
That's
so
right.
That must just be
corrected.
Right. So what we see here, this distribution is really representative of South Africa.
Yeah, and we still only saw mainly the 5 genes. I don't know, some of the other labs or hospitals have sent to in vitae. I don't know whether they can corroborate our findings, but yeah, that is for 1,000 patients, that's what we saw.
I see Chantel has got a question, so maybe you can also enlighten us a bit on the type of genes that's common in patients in your private practice.
Hi, thank you, Nerina, for the talk. It was very informative and I really enjoyed it. I did unmute myself, hey, just checking. So I actually have quite a few comments, but I don't think there's going to be enough time. So Nerina, I'm not sure if you know me at all. So just
I know about you.
Yes. So just for the group, so I mainly work in private. So I see mainly private practice patients, and about half of my patients, they cancer genetics. And what is quite interesting, because I know that you've been talking about the smaller panels, and I think this also adds on to what Monica was saying. So for us, for our unit, for instance, we see 2 variants in the ATM gene quite often. So we see it more often than the PALB2 and the CHEK2. So for our center, for instance, I would have, if we do like a smaller panel and we've got founders, I would have wanted to include those. So I do think that the genetic testing, it's quite like center specific, and what the particular center would need. Because even if I look at the distribution of mutations between the patients in the southern suburbs and the northern suburbs, it also differs, which makes it tricky, obviously, with cost implications. And I also think with the private patients, you know, cost for many of them, cost isn't an issue. But for the state sector patients, it's very expensive. And they, like, if you're not on a medical aid, it's quite difficult to pay for the panels. So I think when working with the patients, you also need to like consider all the factors. And I think that's something that I would definitely want to have, is if you're thinking of smaller panels, I would want to have a discussion on what our center would need, because I think it would be a little bit different than what was presented. Because it's like a little bit, it's not major differences, but it's a little bit different.
I don't know whether I did not come over right. What we are thinking of is BRCA1, BRCA2, PALB2, TP53, ATM, CHEK, and potentially BART. That's the core genes I would think we should keep.
Okay, so not like the founders specific, because I know that you said with the BRCA to start with like the BRCA founders, BRCA2 founders, and the CHEK2 founders. So not to do like a small panel rather than start with the founders.
I don't know. What I did say is that we should not do all 9. We are barely, I know it can differ between the various regions. So, but we are not seeing the Ashkenazi Jewish variants a lot. We are not seeing some of our Afrikaner BRCA1 variants a lot. So I would say the main 2 that we are looking at for a first tier, very small, limited test would be the 5999 variant as well as the 8162. And then because when I looked at the panel data and I saw that we picked up the Czech European variant C1100 4 times, I thought, well, then actually we should include that one. But that should be a very small genotyping based assay. And then I would do at least, let's say, a 7 gene panel, and not necessarily a 15 gene panel.
Yes, and the other thing is, because with the genes is, so at our center, we actually see the RAD51C and the RAD51D quite often. So that's like 2 genes that I would have wanted to add. But I mean, once again, I'm talking from like our center in private practice.
Yes.
So, and I also think that when like establishing these panels, we need to think, what are we aiming at? Are we doing it just to discover like the benefit of predictive testing? Are we trying to also do it like therapeutic targets? Because that's why the whole ovarian cancer thing is so big at the moment. Because the thing with POPs in the state sector is it's not available in the state sector, and it's very expensive. I don't think any of the state sector patients would be able to fund it themselves. So this is just like thoughts that I think should be considered. And I think you should market it to the patients in that way as well. To make a comment about the male patients. So I've also worked with urology for many years. So I've worked with quite a few prostate cancer patients, and I've now been trying to promote testing for the prostate cancer patients in the private setting, because now I obviously know quite a few urologists. So the issue is that they actually refer the men to me but the uptake. So I get the referrals, but they just do not want to come and see me, because I think they just do not get the value of the genetic testing at this stage, because the PARP inhibitor is not has not yet been approved by the South African medical aids. They're busy with it, and I'm hoping that it's going to come through in the next month or so. But it's just like, even if we make contact and we try and explain the benefit, it's just they are just not keen on coming to the hospital and having another blood sample taken. So I don't really know how to fix that barrier, because the information is out there. They're just not wanting to come. I have had some success if the men have daughters, because I can sort of say like, listen, it's not just about you, but if it's men that have sons, they're less likely to worry about their sons, which is also an interesting finding. But this is just me from my experience, but I think it would definitely be a nice research study for like a genetic counseling student, to try and understand why these men are not wanting to come when it has like a therapy. But yeah.
Thank you,
That's just a
Chantal,
comment.
for the comment. Yeah, that's an area that definitely needs some work, and we need to understand a little bit better, and then they need to understand a little bit better. But I think we
I
will
was
always
actually-
have this.
Yeah, I was actually thinking like, because you have these lives in
You break it up
things
a
like
bit.
yes, so I was saying like with the breast cancer months, you've got these massive drives for
Yes,
BRCA
yes.
testing during that. So I was actually thinking, because you've got Suits Up September, which is a massive drive for prostate cancer, to not try and get like the BRCA testing as part of that as well now, like to incorporate it in that big drives, because it's not being incorporated at all. I don't know if that would like make a difference.
Yeah, no, that's true. Anything that can make a difference is valuable.
And that's just me, random, like
Nicole van der Merwe,
Claire was
is she
saying.
still here? Nicole? Because she has done this point of care testing. I'm just wondering, with the BRCA, isn't that something that
Claire has just asked a question as well. But
Claire, you can ask your question.
testing.
Hi, Chantal. So
Um,
it was just a comment to you about whether the
But you
urologist, for
can come.
example, mainstreaming testing might increase uptake for men, because they just don't like the idea, I suppose, of counseling. But again, I'm generalizing.
Yeah, so it's like even with the mainstream testing, it's so at the moment things are a bit different. So the with the mainstream testing, yes, like I agree. Like I always say, like if you have the patient in front of you and they hesitant to see a genetic counselor, like some testing is better than no testing. But the issue is that the oncologists and the doctors, with like the cost, I think cost is also quite big at the moment. I think that also plays a major role with the testing, because like with the, even if you did like the BRCA founders, we're hoping that we'll find something, but we won't always find something. And then you're going to the larger panels, and then when they're here, they have to pay about 8,000 Rand, or between 6,000 and 8,000 Rand for a panel. Then they're hesitant to pay that because they're just not seeing the value. So now the oncologist can't sort of motivate them to be tested. So now they're hoping that the genetic counselor will get it right in more detail, but then they just never show up. Patient that I counseled with his wife explained the whole testing, and he was sitting in front of me with his wife. I gave them the testing form, and he actually did not go and have his bloods taken. Because once again, because of cost. He had the founders done because it was covered by his medical aid, but he did not have the full panel done. So I think it's a combination of things, and that's why I feel like a research study, because we've done countless research studies on the women and why they do not want to go for genetic testing, but we haven't done that for the men. So I do think it would be a nice project.
No, I agree with you.
Okay, is there any other questions or comments? Otherwise, we can end the session. It was quite a long one. I don't know if there's many written questions that I missed. Let's just see.
It's basically only comments. I don't see any other questions. Oh, there's one from Sebastian Barnard that wanted to know about our workflow. If we do pick up a CNV, is it confirmed with MLPA? Currently, we do confirm all BRCA1 and 2, some of the ATMs, the TP53s, and what's that one, the fifth one? Check 2. But not all the exons. We want to purchase, we want to move that over to digital MLPA, in which we will have, then we can screen or confirm all the CNVs that we do detect using digital MLPA, but we don't have that as yet. So we stuck to the first 5.
Just a technical comment there. When NGS started, everyone was, you have to Sanger confirm every region. But once you validated your assay, secondary confirmation is not always required. In NGS, because you're trying to cut down on your primer costs, a lot of the companies save money or cut down expenses by designing a single primer or single primer pair or amplicon per target, which decreases the total amount of primers. But when you're doing CNV analysis, the more amplicons there is, the better the CNV detection rate. So we do MLPA confirmation, but most cases for tricky regions where there's a exon only covered by a single amplicon pair based on our assay. But the moment you have multiple amplicons for target or multiple exons, then it's not always required to do MLPA as confirmation, and this was pre-validated in our workflow.
So I hope that answers Sebastian's question.
Okay, so I think then at this note, if there's no further comments or questions, I think I just want to, it's only left for me to say thank you to your very comprehensive talk. I could see there was I think this is the maximum number of people that attended the talk up to date. Barbara, you can confirm it was 60 at one stage. So really, Nerina, I think it is just showing, how important this work is. So you can feel very proud. One's always a bit nervous that there would not be enough people to justify, inviting such important speakers. So yeah, so everybody, this is then the end. Thanks for everybody that participated, and especially RISPA for all the oncologists and the pathologists that you invited from Kenya. I hope that we can have more representation from other African countries. But I think it will happen over time. And Nerina, I think everybody here would agree that we could maybe use this distribution, these names to, for you maybe to invite them if they want to participate in these plans. I know we may need a bit of time to think everything through. But if there's no problem with people, I think we can share this distribution list, and then we take it from there. Thank you.
Yes. Okay, it's a pleasure. Have a good evening, everybody. Sorry.
Thank you very much. Thank you. Thanks so much.
Okay.
Bye-bye.
Bye-bye.
Bye.
Chantal, did you see this question about the uptake? I don't know if she's still here. It's just a typed question.
The uptake?
It says, with mainstream testing.
Oh yes, Claire. Yes, that was
Okay,
when
that's
Claire
okay,
and I spoke to each other. Yes.
Okay, so there's quite a lot of interest in your the point that you made. So that's very good. Yeah, so it looks like you can work on BRCA1 and 2 with breast cancer, but when it becomes another cancer for the same genes, not the same, one would assume that you would have the same reaction, but not necessarily. So every time there is a new thing that needs to look into.
Yeah, but I think it's just because it's more a male cancer than a female cancer. So with the ovarian and the breast, you have the same uptake because it's like two cancers that affect the females. But obviously with male cancers and in general, with all the genetic studies that we've done, the uptake of genetic testing amongst males are lower than amongst females. So I just think we need to have those conversations. And usually with qualitative research, the females are more, or the women are more likely to be willing to participate than the men. But yeah, I think we'll think of a solution, and I'll definitely be working on like awareness campaigns in the future.
Yeah.
So
I see this question also that this Dr. Yafta who asked, I'm not sure if she's still here, is the 15 gene panel covered by medical aid? Yeah, so this test is still done in the public sector, and for all those patients, the government would pay. But it might be a good idea, because I know that the NHLS can also test private patients, because we have seen a few. So I think that is a good thing to take up with the medical schemes in South Africa, because I know that they prefer to pay for tests that's done in South Africa. So we can maybe try that. Okay, thanks a lot.
Okay, Marina, have a good evening.
Thank you. Bye.
Bye-bye.